Hi, my name is Jacqueline Wilson. I'm a registered nurse and doctoral student at the University of Calgary.
My name is Puneet Punian, and I am also a registered nurse and a research assistant at the University of Calgary.
Today, on behalf of our multidisciplinary team, we will be presenting the top 11 research priorities for families in Alberta, a summary of the Family Research Agenda Initiative Setting, or FRAISE, project.
We have no conflicts of interest to declare.
Over the course of this presentation, we intend to briefly outline the importance of engaging families in health research, describe the FRAISE project and the priority setting partnership that we used, speak to the top 11 research priorities identified in collaboration with families, and finally, share the lessons that we learned and implications for practice.
Researchers and practitioners currently lack a broad understanding of parental concerns regarding children's health and well-being. Employing an intersectional lens that centers the perspectives of parents and families has the potential to generate evidence and policy that accounts for their diverse needs. Determining and investigating parent-identified research priorities may contribute to meaningful health outcomes for families by enhancing family services, increasing the uptake of research in practice, and empowering parents.
Previous engagement of parents and providers has focused on identifying parental preference for information delivery and barriers to services. There's been very little attention given to identifying the health research priorities of the families themselves. As the evidence supporting healthy developmental outcomes for families grows, research investment should focus on understanding relevant priorities for families. This can inform cost-effective policies and programs, as well as reduce research waste. Our multidisciplinary FRAISE team set out with a goal: to work with parents and providers to create a top 11 list of research questions for parents and caregivers in Alberta. For our priority setting partnership, we used a strengths-based and consensus-building approach, which was implemented in 4 phases. We used a modified James Lind Alliance approach, as the conventional approach is resource-intensive and may be impractical for lower-resourced research studies and those working with vulnerable populations.
This approach was chosen for a number of reasons, which includes the ability to bring together clinicians, researchers, families, and vulnerable populations to collaboratively identify research priorities and enhance engagement in services that support early childhood health, and increasing researcher accountability and contribution to the development of culturally and socially meaningful outcomes. In Phase 1, a steering committee of parents, clinicians, community agency representatives, and researchers was formed. At each committee meeting, parent participants were provided with a $50 honorarium, free childcare for participating, and meals throughout each session. Upon the first meeting of the steering committee, 12 categories of interest for young families in Alberta were established.
In-person collaboration with steering committee members was used to develop an electronic survey to assess research priorities across the 12 parenting topic areas. The survey was pilot tested with a small group of Alberta parents and then made available via online and in-person recruitment. Surveys could be completed by parents, caregivers, and community agency representatives. We hosted a series of in-person survey completion sessions at various community and healthcare agencies as well. This provided increased access to underrepresented populations, particularly those without reliable access to the internet. Within the survey, participants were able to answer the open-ended question: what research topics are important to you about parenting children up to 24 months and the pregnancy period? Participants could then rank the 12 broad parenting topics and list their specific questions and concerns relative to each topic.
In Phase 3, the steering committee used a series of online and in-person consensus-building workshops. The committee condensed the roughly 3,200 research priorities that were received via the survey into themes and then established the top 34 questions. These questions were then circulated to the broader steering committee via online survey. Finally, the steering committee met in person to determine and rank a top 11 list of parent-identified research priorities. Selecting 11 priorities as opposed to 10 was the consensus of the steering committee. Finally, throughout the project and currently ongoing has been Phase 4, which is knowledge mobilization. Researchers and committee members have been participating in report writing, social media outputs such as blogs and infographics, conference presentations, and manuscripts.
Ultimately, 596 individuals consented to participate in the survey, of which 479 completed the survey. 68% of participants completed the survey online, with the remaining 32% recruited during targeted in-person sessions where participants completed the survey on a tablet. 72% of respondents were parents, and a majority of the respondents had 1 to 2 children.
A majority of the group had received some post-secondary education and had an income over $40,000 per year. Over 15% of the responses were from fathers. Over a quarter of our sample was from a visible minority, and 20% were born outside of Canada. The socioeconomic, ethnicity, and geographic distribution of participants was comparable to population distributions of Alberta.
As you can see here, the top 11 research priorities are diverse. Parents repeatedly specified the need for structural health system changes at the individual, family, community, and government levels to have an increased focus on building emotional and mental well-being, physical health, and healthy relationships.
Following the priority setting partnership, 19 out of the 22 attendees chose to complete the evaluation survey, with 84% of steering committee members agreeing that the final top 11 list was definitely accurate and representative of the group's consensus. At conclusion of the steering committee, members were asked to complete the public and patient engagement evaluation tool. Most participants agreed or strongly agreed that they were able to express their views freely and felt there was a wide range of views and perspectives on discussion topics shared.
Throughout our experience with the FRAISE project, we came away with a few lessons that we wanted to share. First of all, not all needs and situations can be anticipated, meaning that we had to remain calm, flexible, and creative. At the start, we were not attaining responses from diverse populations. So as a result, we added in-person recruitment to target vulnerable populations, such as individuals new to Canada, and populations often underrepresented in family health research, such as dads. We leveraged our community relationships to create these in-person recruitment opportunities. At steering committee meetings, we ran into unexpected accessibility issues. Parking was far from the door and there were no elevators, which made it difficult for parents to access our meetings due to their children's strollers. Thankfully, our amazing research team was willing to step in, help out, and do some heavy stroller lifting. Although these engagement strategies were great and they allowed us to diversify our sample, it was not without a considerable amount of resources, troubleshooting, and time. For example, additional research assistants and tablets were needed to travel to community agencies for in-person recruitment. Steering committee meetings also required a considerable amount of resources to manage logistics. To increase engagement, we used gift cards as an incentive for survey respondents and steering committee members. Furthermore, at meetings, we needed to provide childcare in a separate room to not disturb parents while they were working. We had to provide toys and games for the kids, we had to organize damage insurance, and we even had to learn how to remove Play-Doh when it got stuck in the carpet of our rental space.
We aim to create a safe, inclusive, and respectful environment from the start through our commitment to remain flexible and respectful of our parents' busy schedules. Ground rules were also established to increase participation and create a respectful environment where all opinions were valued. Our feedback was very positive. For example, one participant commented that there was no judgment passed and different viewpoints were allowed to be given and discussed before a consensus was reached.
The findings from this project will direct targeted research rooted in parent-identified priorities, which will inform the delivery of equitable and improved interventions. However, to move forward with these priorities, multiple stakeholders must be engaged at a variety of sectors and disciplines. Because we included policymakers and committed to strong collaborative partnerships at each stage of the process, provincial health services have already applied these findings to streamline the delivery of evidence-based information to parents and families in Alberta.
We gratefully acknowledge our funders and supporters.
We would also like to acknowledge our parent, clinician, and community partners, as well as the families who participated in this work.
Thank you so much for watching.